السلام عليكم. بشكر حضراتكم اساتذتي الكرام، وبشكر كل الحضور من اساتذتي وزملائي واخواتي الكبار والصغيرين على الدعوه الكريمه دي. انا اتشرفت جدا ان انا موجود معاكم. انا هيثم عادل، Alexandria Police Hospital. I am very happy to be with you today. انا هستسمح سيادتكم المحاضره بتاعتي شويه، احنا في وسط وحوش انف واذن ومخ واعصاب. المحاضره بتاعتي شويه موجهه للجيل اللي من جيلي اصغر شويه، الناس اللي موجوده النهارده زي ما حضرتك قلت اللي لسه بيبداوا يبقوا انترستد شويه في السكال بيز. فهنتكلم شويه، الموضوع مش هندخل في الدبس، بس هو التارجت ان احنا يبقى عنده معلومه كام بوينت بسيطه يطلع بيها من التوك ديت، مش محتاجين اكتر من كده ان شاء الله. زي ما كلنا عارفين الانتيريور cranial fossa meningioma are benign extra-axial lesions which arise from the arachnoid cap cells of the dura mater. These tumors may invade the surrounding structures and can result in significant morbidity and mortality by virtue of their location. Anterior cranial fossa meningioma account approximately 12 up to 22% of all intracranial meningiomas. They are classified according to their site of origin: olfactory groove, planum sphenoidal, tuberculum celli, diaphragma celli, orbital roof, and clinoidal meningioma. Olfactory groove and tuberculum celli are the most common sites. Ideal management of olfactory groove meningioma is total resection with excision of the surrounding dura and bone. But it is not the complete surgical excision of this tumor is challenging due to close proximity to critical neurovascular structure such as internal carotid artery, anterior cerebral artery, anterior communicating arteries, perforators, visual apparatus, and the pituitary gland. So, subtotal excision and adjunctive radiotherapy can be the option for such difficult to excise tumors. Traditional cranial approaches state large craniotomies, brain retraction, as well as manipulation of critical neurovascular structure, thus increasing the morbidity and mortality associated with open techniques. The evolution of skull-based approaches and microsurgical techniques therefore have significant improvement in surgical and neurological outcome following resection of these tumors. The introduction of endoscopic endonasal approaches to the anterior skull base has resulted in paradigmatic shift in surgical management of anterior cranial fossa meningioma. It has the advantage of minimizing the brain retraction and limited manipulation of the critical neurovascular structure, but complete surgical recession and CSF leak and the infection is still debate. So, the optimal treatment strategy for anterior cranial fossa meningioma should be planned based on complete understanding of merits and risks involved with both open and endoscopic approach. Stereotactic fraction radiotherapy and radiosurgery showed promising results in management of a small or post-operative residual. Olfactory groove meningioma account for 34%, orbital roof meningioma 4%, planum sphenoidal account for 5 to 10%, tuberculum celli meningioma 70% of all anterior cranial fossa meningioma. Diaphragma celli meningioma, it is the three types. Type A arising from the upper leaf of diaphragma celli anterior to the pituitary stalk. Type B from the upper leaf of diaphragma celli posterior to the pituitary stalk, while type C arising from the inferior lobe of diaphragma celli. Type C involving the cella and cause enlargement, mimicking pituitary adenoma. It is very important to differentiate between them. Anterior clinoid process meningioma account 24% of all anterior cranial fossa meningioma. Imaging characteristic: MRI is the imaging modality of choice. MRI helps to delineate the extension of the tumor and its relationship to the surrounding neurovascular structures. CT is very important to show the presence of intratumoral calcification, which can be seen up to 20% on olfactory groove meningioma. Digital subtraction angiography is helpful in defining the vascularity of the tumor and the predominant feeder. These tumors are well defined, enhanced brilliantly with gadolinium. T2 weighted image demonstrate fluid voids. Source of the blood supply can be shown as the meningeal branches arising from the anterior and the posterior ethmoidal artery. In planum sphenoidal and tuberculum celli meningioma, the optical apparatus is placed superiorly and posteriorly, and the anterior communicating artery complex is placed superiorly. Characteristically, the cella appears normal in size and surface, and these findings help to differentiate this tumor from pituitary adenoma. Bone changes can be noticed include blistering, hyperosteosis, and erosion. In type A and B, diaphragma cell meningioma, the cell will appear normal, as we said before, but in type C meningioma, the cell is enlarged. How to differentiate it from pituitary adenoma? By enhancement brilliantly. In clinoidal meningioma, hyperosteosis, calcification, and diffuse edema can be seen in addition to the previous characteristic. Here we can see a case of tuberculum cell meningioma with visual affection. In this case, a case of calcified planum sphenoidal meningioma. This is the image of patient with large anterior cranial-based meningioma located in the midline, involving the olfactory groove, planum sphenoidal, tuberculum celli, and reaching up to the cella. Here we can see a patient with tuberculum celli meningioma extending up to the diaphragma cell. Management of the anterior cranial fossa meningioma. Here we are not talking about the surgery. There is no definite strategy, but there is differentiation between open technique and endoscopic technique. The terional approach is the workhorse for lesions located in the supracellular region, wide frontobasal exposure, and provide access to the supracellular area. This approach is employed for tumor located in the midline and eccentrically to one side of the anterior cranial base. Tumors arising from the planum sphenoidal, tuberculum celli, diaphragma celli, and the anterior crinoid process. But the terional approach can be limited, and it is not suitable for the olfactory groove meningioma due to its anterior location. And it is unable to visualize the vascular structure on the other side of the tumor. So we can go for the anterior subfrontal approach. It is very important, and it gives you access to tumors located in the midline from the olfactory groove area to the diaphragma celli. Transbasal approach and the extended subfrontal approach are modification of this technique. It gives you advantage of anterior direct equal exposure of the entire tumor, ability to visualize the optic chiasm and post-optic nerve and the entire attachment of the tumor. But its limitation, excessive retraction of the frontal lobe, causing contusions of the parenchyma and subsequent cerebral edema. So we can use the anterior interhemispheric approach used for the tuberculum celli tumors. The major advantage of this tumor are the disadvantage of the previous approach. Its ability to expose the superior limit of the tumor without having to retract the frontal lobes. Use of a lumbar drain using during the surgery help to relax the brain. Lateral subfrontal approach is main for the supracellular region. This technique gives you the advantage of requiring small incision, no risk to injury of the branch of the facial, upper branch of the facial nerve, and having an excellent cosmetic results. Here is the algorithm between choosing the technique. Medial approaches provide satisfactory results for olfactory groove meningioma, whereas lateral approaches enable sufficient exposure of the visual apparatus for planum sphenoidal meningioma or tuberculum celli meningioma. Here we can see when to go to for median approach or lateral approach. If the tumor proximal to the anterior circulation, go for medial approach. If there is affection of the ethmoid bone or cribriform plate, go for median approach. No infection. If there is volume with relevant mass effect and the edema, go for median approach. If there is multi-morbidity, go for lateral approach. If there is infiltration of the optic nerve or optic chiasma, go for lateral approach. If there is presence of infiltration, go for lateral approach. The adverse effects of each approach, we are talking about postoperative epidural hematoma, and subdural hematoma and CSF leak. The tumor volume was significant risk factor for developing a CSF leak. Adverse effects according to the approach. For the medial approach, the abscess and the hydrocephalus and CSF leak were the most dominant, and for the lateral approach, extradural hematoma and subdural hematoma and the hydrocephalus and CSF leak are the most common adverse effects. The endoscopic approach is suitable for small or medium-sized tumor located in the midline without involvement to the vascular structure, without significant or superior or lateral extension. Here is a simple scoring system. Factors associated with incomplete surgical resection via endonasal route. Number 1, presence of hyperosteosis. Number 2, cavernous internal carotid artery involvement. Number 3, maximal dural tail length in the transverse plane and its ratio to the interfovea isthmoidalis distance. Using multiple regression analysis, the cavernous internal carotid artery involvement and a large dural tail length to the interfoveal distance ratio were significant predictors of incomplete resection using endoscopic technique. Stereotactic radiotherapy and radiosurgery are alternative treatment options for such residual or inoperable tumors. They achieved up to 95% of cases local control, and more than 90% of 5 years tumor control. And the stereotactic radiotherapy is useful for larger tumors more than 3.5. In this case, we can find the tumor filling all the nose and paranasal sinuses and the left frontal sinus. As we can see, here we can see the left orbit is affected. Don't forget the cosmetic opening. Here we can see the degloving. Here we can see craniotomy. Here is the part of endoscopic repair using multi-layer technique. Here is the tumor after near total gross resection. Here after 1 week you can feel the affection even before removal of the nasal bag. Our conclusion: anterior cranial fossa meningioma are benign, slow-growing tumors and they tend to be clinically silent. They can result in significant morbidity and mortality by virtue of their location. Surgical techniques must be tolerated according to the tumor location with the aim of achieving gross total resection with low incidence of complication. Open microsurgical techniques achieve a higher rate of gross total resection with lower rate of post-operative CSF leak. However, with the introduction of newer techniques such nasoseptal flap, multilayer closure, gasket seal to achieve less post-operative CSF leak, endoscopic intranasal approaches can be a better alternative for small midline ventral tumors. These minimally invasive approaches reduce the morbidity associated with surgical resection of this tumor at the expense of gross total resection. Stereotactic radiotherapy can be adjunctive or alternative treatment option for patients with a small or residual tumor. Our take-home message: you must work in a teamwork. Don't forget to respect the learning curve. وحابب اشكركم جدا على وجودي النهارده، وشكرا دكتور عبد الرحمن، وشكرا اساتذتنا الكرام كلهم، وشكرا على الدعوه الكريمه دي.